Okay.
This meeting is being recorded.
All right. Well, thank you everyone for coming to tonight's Ask Me Anything event. It's an honor to be here tonight and to facilitate this conversation about feeding tubes and nutrition. An extra special thank you to our panelists tonight who are volunteering their time and their energy. And they're also willing to share about their experience with feeding tubes. So thank you all so much for participating. As you heard earlier, we are recording this event, so just be mindful of that. We will be uploading this event later to our YouTube channel, so you can keep an eye out for that if you're wanting to rewatch this later. I wanted to provide a little bit of history about I AM ALS. I AM ALS is a patient-centric movement revolutionizing how to end disease. We provide critical support and resources to patients, caregivers, and loved ones. And we empower advocates to raise awareness and lead the movement against ALS in driving the development of cures. So what is an Ask Me Anything ALS? AMA, or Ask Me Anything, is not just a fun social media trend. For those of you who are savvy on social media, this event was an idea born out of the I AM ALS community, where ALS advocates living with and impacted by ALS come together to answer questions from an audience of people who are interested in this specific topic. So a few housekeeping things before we get started. Again, this event is being recorded, and just a note about confidentiality. If you are adding messages to the chat or you come off mute, just be mindful that it is recorded. And if you don't want your name to be read aloud, I'll actually provide some insight about that in just a second. We encourage you to use the chat feature to join in on this conversation. However, we will likely not be reading the chat today just because of the large attendance tonight and the high volume of pre-submitted questions. So if you do submit questions, we have decided after the number of people registered for today's event that we will likely be doing a part 2 event. So if you do have questions, please continue to put them into the chat and we will collect them. We will pull all of those questions that are submitted into the chat feature, and we'll try to do our best to get to them in a second event. The date of that is to be determined. And if you wish to remain anonymous when asking a question, you can send your questions directly to Emily Johnson using a direct message on the Zoom chat. Again, you can send questions directly if you don't want your name read aloud to Emily Johnson, who is employed by I AM ALS, and she will ask your question anonymously. You can also use the raise your hand feature to participate in tonight's discussion and share your own experience or answer a question. And to raise your hand, you would just click on the reactions icon in Zoom and then click raise hand. We do ask that you mute yourself when you're not speaking, as this will allow the discussion to flow without interruptions or background noise. You may have received it already. We've sent out the bios of all of our panelists tonight over email. My colleague Hope is going to introduce herself shortly, and then we will get started with questions that have been pre-submitted ahead of tonight's event. So I will stop talking and pass it over to Hope.
Hi, everyone. Thank you, Mackenzie. My name is Hope Fueling. I'm an ALS support specialist at I AM ALS. The ALS support team works to support individuals impacted by ALS with their emotional and practical needs. This includes providing and facilitating access to information relating to understanding ALS and care options, insurance and legal assistance, assistive devices and equipment needs, amongst other services. So if you have any ALS-related needs that we cannot directly assist with, we do our best to connect you with the correct person or organization that can. I know that ALS can feel overwhelming to navigate and talk about at times, especially the larger decisions and planning that comes along with it. So I'm here today just to kind of provide emotional support and resources as our wonderful panel members discuss feeding tubes and nutrition. Please know that anyone joining this call can reach out to me directly using the Zoom chat feature. I'll also be reaching out to different people throughout the call if I think that an email follow-up may be beneficial. Myself and the rest of the I AM ALS support team can be reached at gethelp@iamals.org, which I'll put in the chat momentarily. So please reach out at any time if you'd like any support from an ALS support specialist. Thank you.
Thank you, Hope. Okay, so we will get started with questions. To start off, we received a lot of questions ahead of the event about the timing of when to get a feeding tube and how do you know when the time is right. If the panelists are comfortable with it, let's go ahead and start here. How do you know it's time for a feeding tube? At any point, is it too late to get one? Sandra or Sarah, do one of you want to start off with an answer to that question?
Sandra and I will respond to that. Do you have something prepared? Okay, so she's using a speech device, so hopefully you'll be able to hear it.
As soon as I had lost 7 pounds, my urologist said it is time for the feeding tube. Rescheduled for the next week.
So what I would add to that is the timing. I would say it kind of boils down to two things. If you start to lose weight, or as soon as you begin to have trouble swallowing, you want to be ahead of the curve and not behind the curve. So you don't want to lose significant weight. And if you've already started to have trouble swallowing, you may be taking a lot of nutrition in, but maybe it's not quite enough. Or if you start to lose weight. And both of those things, I think, are pretty key points as to when you should go ahead and go ahead and get a feeding tube.
Absolutely, Wayne and Sandra. Everyone, I'm Sarah Lupino. I'm before I answer the question, I just want to give the context. I'm a nurse practitioner in the ALS clinic at Massachusetts General Hospital in Boston. So I talk to a lot of folks about feeding tubes. I conduct a lot of the pre-op visits for feeding tubes, and I help troubleshoot a lot of the care at home for patients with feeding tubes too. So I would just echo what Wayne and Sandra said and add one more thing. When people ask me, like, when's the right time for me to get a feeding tube? It's a very personal decision, I would say, and it varies from person to person, and there isn't a one size fits all approach. So, but I would say if I were to break it down into like the three big sort of red flags or sort of findings that we might say, okay, let's think about feeding tube. One would be, just like Wayne and Sandra said, weight loss. So having trouble keeping on weight would be a reason to think about it sooner rather than later. Second would be swallow changes. So choking on foods, having trouble just eating. And then the third big one would be breathing that I would add too, just because when we're thinking of any surgery in the setting of ALS, we always want to keep an eye on the breathing. And if that's starting to be affected, and there's a possibility that we might need to give anesthesia in the setting of a surgery, the risk tends to go up related to surgeries as the vital capacity. That's the breathing test that we do in clinic to measure the breathing muscle strength. As that score starts to go down with disease progression, the risks start to go up. So sometimes, even if somebody's maintaining weight okay and their swallowing's pretty well preserved, we might think about feeding tubes sooner rather than later from a breathing perspective. Some people also, I would just add, find that a feeding tube can help if they're having trouble physically feeding themselves too, like bringing food to their mouth because of arm weakness. That could be another reason why we might think about it.
Thank you, Wayne and Sandra, and also to Sarah for answering that first question. The next question is similar, but slightly different. The question came in that just said, how long should you wait before getting a feeding tube? Why do people get one proactively, and what's the benefit of getting one proactively? And Sandra or Julie, or both of you, I'm wondering if you can field that question.
Oh, do you want me to go first, Sandra? Perfect. So I guess there's no right answer to how long you should wait before getting a feeding tube. But I think that you should work with your neurologist or your clinic people and follow what's coming on. Like my lung capacity was being reduced, but I could still eat and swallow and do everything else. So we decided to do mine proactively, and I got a feeding tube and didn't really use it until I was hospitalized. May of anyway, so I didn't use it. Now I use it more frequently, but I know that if I waited, I would have had way more problems.
Hey, this is her husband, John, and I know this nurse practitioner had it right on the head there. It's really a function of FEB and a forced vital capacity. I mean, for most people, I think.
The other thing I would say, Sandra's written here that don't wait to have a conversation about a feeding tube until you feel like you might need it. You can have that conversation early in your disease process and talk about it with your neurologist and your team in your clinic, because the sooner you have that, if you already have reached a decision, then when it appears to be time, it's a pretty quick process to get done. But if you're having to think through it at the time you need it, it might postpone you getting it. The other thing I would say for Sandra was she was still eating pretty well. She had lost a little bit of weight, but she was still eating pretty well. But it was creating tremendous anxiety when she was eating. It was very stressful for her to try to eat a meal, and it took a long time. And it was like, as soon as the feeding tube was in and we could bypass that stress, it was a huge relief for her to not be dealing with the anxiety of, am I going to choke on this bite? Am I going to, have trouble getting my medication down? And all of that goes away very, very quickly. So I would say anxiety plays a big role too, in terms of, or in some people, in terms of when to get the feeding tube. And I would just comment, I'm a family physician, I'm retired. So some of what I say will come from a medical background and some will come from just personal experience.
I'd also jump in and just add to these fantastic comments that from a logistical perspective, you can have a feeding tube and still eat and drink by mouth. That's one of the most common questions I get in clinic is, if I get a feeding tube, does that mean I have to stop eating and drinking and just use the tube? And the answer is nope. As long as you feel comfortable eating and drinking by mouth, you can do both. Or like Julie was saying, you could get it really early and not use it. And so there's a variety of ways in which you can use the feeding tube.
Thank you for answering that. The next question is going to be for Justin. And this question came in, it said, initially I said I didn't want to get a feeding tube, but now I do want to get one. Is it normal to change my mind like this? Have others had an experience like this?
Yeah, from my experience, I think it's completely normal to change your mind or to go back and forth. For me, when my doctors essentially approached me with, hey, it's getting time for you to get a feeding tube, it was due to my breathing numbers dropping pretty significantly. Especially, they gave me the threshold of like 50. Once it drops below there, that's when you really want to start considering the feeding tube. And it really threw me off guard at first because I didn't think I was there, because I was eating and drinking and swallowing fine, but I didn't realize that my breathing could also affect or have an effect on the actual procedure. So it took me off guard. And so at first I was like, I don't really know like how to take this in. I think there's a lot of decisions we have to make as individuals living with this disease that are big decisions. And we tend to go back and forth, and I think that's completely fine. You know, when my doctors told me that, I talked with my wife about it, and we know that we knew that, okay, there's a certain, I have a certain goal. I want to be able to at least be around to see my youngest son graduate high school, and so in order for me to do that, I'm going to need a feeding tube, and so that helped me make my decision. But there's still that, even leading up to it, I'm like, is this something I'm ready for? So I think it's completely normal to go back and forth. There's nothing wrong with that, because these are big decisions.
I'd like to add to that. When I was initially diagnosed with ALS, and my husband and I were driving back from the Mayo Clinic, we started having discussions about feeding tubes and tracheotomies and all this stuff. And we were still absorbing, holy crap, I have ALS. So my first response to both of those was a hard no. I'm not doing this. And then when the time came that my doctor recommended I get one because of my breathing, I thought, what the heck? You still socialize, you're going places. Why are you going to die of starvation when you can get a tube? And the bonus is you don't have to taste any yucky medicine.
Thank you for sharing that perspective, Julie. The next question, Julie, is also for you. How can you support someone who is skeptical that a PEG tube or a feeding tube will help? In this case, a loved one has lost significant weight, but does not have swallowing problems.
That's kind of where I was at too. I was losing weight. I was still eating. I couldn't figure it out. And I think that when we have ALS, we're skeptical that anything's going to help us. So we're worried, why do I want to go through the surgery? Why do I want to have something in my stomach? What is it going to look like when I go out? Are people going to think, can they see it through my clothes? So I think you just kind of talk to them, and when they voice concerns, listen, but then respond with, hey, you can get it and never use it. It's no hard decision.
If I could add something too that I think is important, and that is that ALS is what's called a hypermetabolic state. What that means is that you are burning more calories at rest than if you didn't have ALS. So your caloric need actually goes up when you get ALS. And so just trying to keep up with your normal calories and then the extra calories that you need to maintain your weight is significant. So that feeding tube really helps you supplement calories, the extra calories that you need just to maintain your weight. So just bear in mind that it's your basic caloric need increases once you have ALS.
Thank you, Wayne, for jumping in and adding that. As I said at the top of tonight's call, we will not be reading the chat like we often do in other I AM ALS events. And if you're asking a question, we're adding that to a list of questions to address in a second feeding tube event. We had a lot of interest in this one. But I did want to jump over to the question in the chat that said, Julie mentioned issues if she waited. What issues? A feeding tube means I have to move to a nursing home and I'm trying to delay that move. What issues could I experience by delaying? Do any of our panelists want to address that question?
Well, I mean, one thing that you can see happening if you delay it is you're gonna lose a ton of weight. You may die of starvation if you have no way
Right now?
of getting food or nutrition. How are you gonna live? I mean, that's a hard choice. So,
I would also offer that it's not necessarily a linear regression. So sometimes things move faster than you think. And you don't want to wait and then figure out, oh my gosh.
I would also, oh, sorry, Sandra, did you want to say something? Okay. I would also add that from a surgical perspective, we try to be proactive rather than reactive with this type of a surgery, because, you know, we do use the American Academy of Neurology has stated that 50% SVC, which I think we talked about as a cutoff, because we know that the complications with surgeries tend to go up when the breathing goes down. So that's one big driver. And complications could be, and this is not to scare anybody, typically it's a very straightforward procedure from a medical perspective. It's usually done in an outpatient setting. But the sooner we can do it before people have breathing compromise, you know, usually the smoother it goes. Things like, you know, going under anesthesia and having those breathing muscles start to relax, people could be at a little bit of a greater risk for saliva going down the wrong tube and an aspiration event or like a pneumonia infection from that. Sometimes people just have a longer healing time with this disease, because any insult to the body when you're fighting ALS can be really hard to recover from. And I would say, in my perspective, just seeing a lot of people, that the people who go into this surgery, you know, very frail with a lot of weight loss, is just such an insult to the body that sometimes what it can do is kind of tip people into more of a decline, because the stress of the surgery on their body is so much that it's just really hard to recover. It's almost like having a really bad fall or a really bad pneumonia or something. So I have seen people really struggle in the recovery phase, which is why we try to be super proactive about it. With all of that said, I just want to kind of back up and say, when we look at the literature around feeding tube and ALS, from a quantity and a survival perspective, and this is going to sound a little funny, but feeding tube has actually not been shown definitively in the literature to prolong survival ALS. There are some specific individuals with ALS who you could clearly say, if, you know, somebody with ALS is earlier in their disease progression and they really just can't eat or drink, theoretically, a feeding tube will likely prolong their life, right? Because you need food and water to survive longer. But if you look at the full spectrum of the ALS population, knowing how variable this disease can be from person to person, the literature is not really showing that feeding tube is significantly prolonging survival in folks. So where that really leaves us when we guide folks on this decision is, what is this from a quality of life perspective for you? Where could we see feeding tube being a tool to solve a problem? And I think, you know, a lot of us have just named a lot of areas where feeding tube has hopefully made things easier in their day-to-day and not harder. And so I just want to say that, and also just note that I do talk to folks a lot about feeding tube, who say, like, this is not something that I want, and you don't have to get a feeding tube with this disease. And there are some people who just say, that's not for me. It's not within my goals. And that's okay too.
Absolutely. Thank you, Sarah, for that reminder that what works well for one person doesn't always work well. Never. It works well for everybody. So just remember that your experience is your own, and what works well for someone else may not be the best course of action for you. I want to hop over to talking about the procedure itself, of what it's like to actually have the surgery to have a feeding tube placed. Wayne or Sandra, I'm wondering if you guys can share more about the prep and procedure required for getting the feeding tube.
Sure. Honestly, that there isn't a great deal of prep that goes into getting ready to get a feeding tube. I mean, a lot of what you'll need to have done is probably going to have been done, like your FVC in clinic. And so the feeding tube placement can be done either under local anesthesia or under general anesthesia. And there's pros to each one and so forth. And I think that's a discussion you'll have with whoever's going to place that feeding tube, whether it's an interventional radiologist or a gastroenterologist, or even a general surgeon. I think those are questions that you'll discuss with the individual. So there's not a lot of prep that goes into it in preparation. I think, normally you'll have nothing to eat after midnight so that you have an empty stomach, and then the procedure is done generally in the morning because they don't want you to stay without food for an extended period of time. And then normally it is an outpatient procedure, and you go home later in the day, and actually go home a little sore, but it's certainly not terrible as far as surgical pain is concerned. And but it's sore, and it probably takes probably a minimum of 2 weeks before most of that soreness is gone, and probably at least a month before that stoma has matured. That's another discussion, but it's as procedures go, surgical procedures go, it really is pretty straightforward and pretty simple and very well tolerated the huge majority of the time.
Thank you, Wayne. You mentioned this briefly, Wayne, but I'm going to circle back to this idea of being fully sedated versus just having local anesthesia. I'm wondering, Justin or Julie or other panelists, can you share about your experience having the placement procedure fully sedated versus only with local anesthesia?
I'll start. I agree with Wade. It's whether you choose to be fully sedated or a local anesthesia, that's up to you. It's up to you and your doctor. What level of anxiety do you have when going into a surgical procedure? That it's also obviously going to play into your decision. For me, my procedure was really straightforward and quick. The longest part of my day was waiting to actually go into the OR, being in the waiting room, and then going back and then having to wait for the OR to open up. I remember, looking at the clock in the OR, and it was like 2:30, and I felt like I just took a 10-minute nap, and I woke up and I'm like, hey, I don't think this stuff is working. Like, I'm awake. And they're like, oh no, we're done. I'm like, are you serious? They're like, yeah. And so for me, it was like a 10-15-minute procedure. I was then, I had to go to recovery for a little bit before finally just going home, a quick outpatient surgery. But I think you need to consider, what are you comfortable with? What is your level of anxiety around certain surgical procedures? And go from there.
I had mine done fully sedated. I kind of had a conversation with my doctor because I have a super high tolerance for pain and I hate hospitals. But she won because she's a doctor and she's smarter than me, or most days. I didn't fully sedated, but like Justin, it was like, boom, you're done. So, but I did have to stay in the hospital overnight. And I tried, I had no pain. I was like, let me go home. So they said no. So there you go.
My name is Nicholas Martin, and I had my procedure done in the VA hospital, and they kept me for, I think it was a day after, and I think I was fully sedated, and they told me that they would bring me back because we were having a procedure. Otherwise, they would just let me go, and I was on oxygen afterwards also. So. But the reason why I got mine placed was I had lost about 60, 70 pounds, and they didn't know why and things like that. So anyhow, that was but I haven't used the feeding tube. I've just had to irrigate it periodically so that it stays open and clean, and I get a little mucus around it. Have to clean that out. So anyhow, that's where I'm at. So thank you.
Thanks for sharing your experience, Nicholas. Sarah and Julie, I'm wondering if you can talk a little bit about where the tube is actually placed. If I've heard women say before they want it placed in a place on their abdomen so that it doesn't impact where their bra line is sitting or where their pants might be sitting. And so I'm just wondering, can I choose where I put the feeding tube, or does it matter where it's placed? Can you guys talk to that?
Yeah, I can start on that one. So usually in most cases with ALS, the type of feeding tube that we place is called a G tube, which stands for gastrostomy, which basically means it's a gastric tube. It goes directly into the stomach. Once in a while, if somebody has another medical condition or GI issues, they might get a J tube, which stands for the jejunum, which is the small intestine, or a GJ tube. There's all different kinds. But in general, for the most part, for folks with ALS, it's a G tube, so just right into the stomach. The challenge is that we can't really have control over exactly where in the abdomen the tube goes, and we can't really predict for folks. Like, when I sort of will generally gesture to my abdomen, but everybody's stomach is actually in a slightly different location. So everybody's a special snowflake in this department. So we can't really predict until we get into the surgery exactly where that tube is going to land. This could be impacted by just genetics, like where your stomach falls. But sometimes if somebody has had a prior abdominal surgery, their stomach might be slightly shifted one way or the other. Like if you had your appendix out or your gallbladder or your spleen or something like that. And sometimes based on if your stomach's up under your rib cage a little bit more, the tube might have to thread up under and go a little bit higher. And that's where women might find it more in the bra line area, which can be cumbersome and sort of a pain in the butt, to be honest. So we try to work with people as best we can, but usually the tube has to kind of land where it lands. But we can work with the IR team to try to find a type of tube that's most comfortable, that works well for them, and to try to adjust things if we need to through tube replacements after the initial placement, if we can do anything to help with it.
Well, I will add, and I know, sir, you said that you have to have it where it has, but I specifically told my doctor in the room, and I embarrassed him. I said, dude, I have boobs, so please don't put this under my boobs. And when I got on, it's under my boobs, and I was like, what the hell? The only thing I requested. So I have mine under my breast, and I will warn you ladies that once you have that done, trying to find a bra is a royal pain. I probably have 15 bras there that I bought on Amazon that are going to be donated to a women's center because they didn't work. So I did find one, so if anybody needs that information, let me know.
Thank you for sharing that experience, Julie. And I'm sorry that your surgeon didn't follow your directions. How frustrating. The next question is for Sarah, and it's about the different types of tube. And someone asked what works best, and I'm probably pronouncing it incorrectly, the McKee or J tube. And Sarah, I'm going to have you answer that.
Yes, absolutely. We get a lot of questions about this. So there's different types of feeding tubes, of G tubes, if we're going to kind of stick to that department. And the way that I divide it up is like the standard G tube is what I call it. So that's like the long one that hangs outside of the body. And then there's the low profile G tube, which is more like the Mickey button, which is what a lot of people are familiar with. And I have some pictures that I can show. Is this a good time? Yeah, I'll pull them up. This is just from a slideshow I gave a little while ago about feeding tubes. I don't know if we need to get into this level of detail, but this is one of the longer G tubes. So most of them are secured by a little balloon that sits inside the stomach walls that prevents it from falling out. So like, if you can see my cursor, this part on is inside the body, and then this is what hangs outside of the body. And then there's different ports. This balloon port you insert, the surgeon will handle to inflate the balloon upon placement. People don't need to worry about that. And then there's this middle port that's the primary one that folks will use to administer water, medications, and formula. There is a little baby medication port, but most people just put everything through the feeding port, if I'm going to be honest with you guys, because it's just bigger and easier to use. So there's pros and cons. So this is what, as you can see, like in the person's body, like the longer tubing, how it hangs out. A lot of them have a clamp here so that if you open the stopper here while you're manipulating things, you can kind of clamp it while you're grabbing something so that the contents don't leak out. The nice thing about the longer tubing, because I would say I don't have a preference when I guide people on this. I really think it's personal decision, and there's pros and cons to both. Literature doesn't favor one type of tube over another type of tube either. So it really is an individual choice. But the nice thing about the longer tube is that it is easier to grab onto and manipulate. Some people tell me if they have some hand weakness. A lot of people will tape it, use a little gauze tape and tape it against their abdomen to secure it a little bit better if they feel uncomfortable with kind of having it hang around. Even though it hangs out, it shouldn't necessarily affect mobility in a significant way, especially if it's secured. Some people buy like little wraps or kind of belts that you can buy on like Amazon and put around your abdomen to give it extra security. You should be able to roll over, to position, comfortably sleep on your side with it just fine. But some people just don't love the idea of having something hanging out of their body, in which case the low profile tube is an alternative option. And that's what's called, the Mickey is like the brand name of it. So it lays flush against the abdomen. This is actually really popular in the pediatric population because what do little kids do? They grab and they pull. So they're famous for pulling out their feeding tubes. But in the adult population, Mickey tubes have become really popular just because they, like we said, the kind of flat against the abdomen tends to be a preference for some folks. So the way that you use it is the vendor that you would be connected with through your clinic would send supplies. So that would include extension tubing that gets connected to the button. And that's what you would use to administer like water or formula. I would say one thing to think about is that you do need to have a little more dexterity to connect the extension tubing. If you have a caregiver helping you with this, that might not make a big difference either way, whichever tube. But some people have preference over that. Sometimes their caregivers have arthritis or something, and that can be a little bit of a challenge, for example. One thing to think about is that at MGH, for example, typically what our surgeons require is that you first have the longer tube placed because this tube is a little bit bigger and you need it to go in initially to maintain a tract. And then you have to let it heal for several weeks. And then you can come back and have it switched out for a Mickey button. So the structure of the Mickey button, a lot of times folks can't have it placed initially. You have to come back and have it swapped out for a Mickey button. And the exchange for a Mickey button is not done under anesthesia. It's typically just a little local numbing in the clinic, and they just take the old tube out and put a new one in. So that's a little bit about the pros and cons. I don't know if other panel members, if you guys must have some experience perhaps with the different types of tubes and would want to weigh in on your personal experiences working with them.
I have the long tube that you first showed. That was what was given to me. Now my ALS was live onset, starts in my arms. So even since I had my tube placed in last April. So I've never been able to utilize or do it myself. My wife is always the one to flush it or whatnot. So I have that. And like you said, Sarah, I bought because it does hang down pretty far. Even it would hang, sometimes it would hang down below my shirt. So my wife found, like you said, like a band essentially that she got off of Amazon that I could tuck it into. And it's not it doesn't, sometimes you can see it through my shirt, sometimes you can't, it just depends. So that's my experience. And I've considered the Mickey, but I've gotten so used to this that I'm just like, because and I know that with the Mickey, you have to, like you said, exchange it every few months, I believe, correct?
It depends on the tube type. But for Mickey buttons, like at MGH, the general recommendation is like every 6 months-ish, you should have it swapped out for a fresh one.
So for me, like once I found that out, I just didn't want to have to bother with whether it was every 3 months or even every 6 months going to get it switched out. And so I'm okay with what I have. I feel comfortable with it. I sleep fine with it. And sometimes I honestly forget that it's there.
And I'll just say one more thing. Sometimes some of the newer, longer tubes, they're also recommending a 6-month swap out. But there's also, it depends on the brand and the type that your hospital places. So I've also had people have longer tubes that the surgeon has said, like, you're good to go, like you can just keep it indefinitely. But that is a consideration too.
Yeah, I think what I would say, Sandra had, brief story. I mean, she had a Mickey put in initially. Unfortunately, it was a faulty Mickey and it fell out that evening. So we could go back the next day and have another tube put in, which was a longer G tube. And she had that for 2 months, I think 2 months. And then we were back home and one of my gastroenterology partners just swapped it out for Mickey. Now, so she had both. I think there is no right answer to that. You know, what's the best? It's going to vary from person to person. She likes the Mickey because it's not even noticeable that she has it at all. She did have some of the bands that Justin talked about to kind of tuck her longer tube in when she had that, and that was fine. But it was something that could be seen in her clothing, and so she just knew it was there. That's not always true, but I think the other thing I would say about in terms of how long the tubes or how frequently they should be swapped out, I think that's going to depend on your doctor, because it's going to vary from place to place, from individual surgeon or gastroenterologist. Like, for instance, my gastroenterologist said, when it's bad or it leaks or it falls out, we'll put another one in, you know. So her first Mickey was in for a year before it started to leak. And so we swapped it out. Her second Mickey was 3 months before the little tab on it broke off. And then I swapped that one out at home for another one. So it's like, it just varies. I don't think there's a definitive answer about how long you can leave them in. It will depend on your surgeon and your physician.
Thank you to all of you for jumping in on that question. I want to talk a little bit about general cleaning and maintenance of the tube. And I guess we just kind of, conversation naturally brought us here. So I wanted to ask Justin and Julie, what are some tips and tricks you have for cleaning your feeding tube? How often does it need to be cleaned?
Julie, go ahead.
Okay, I'm actually going to defer to my husband a little bit about on this one because I don't do it. But we struggle with that because I'm a little OCD, and when you have feeding tubes, you can see stuff, the long ones that are in there, and I'm like, oh my God, what is that? Am I gonna get an infection? Am I dying? My husband is like, you're crazy, just leave it be. So he found, and this is where I'll turn it over to him, This is John.
Well, I did find something on some page regarding ALS, and I'm fairly sure that everybody's going to, at least any physician is going to tell me you're incorrect for doing this, but whatever. But they do make flexible stainless steel braided brushes that are nylon, and so they have the length of the fiber is not very long, and you can basically kind of scrub it, if you will. It does have a very easily recognizable white tip that prevents it from snagging on the tube. So you're not worried about punching a hole in anything. And of course, you would never go any further than approaching maybe the abdomen. And it's amazing the difference before and after. Something is very opaque, becomes very translucent afterwards, and then you just flush it. But even in that, there are certain things that you would give a person via tube that tend to stain it, and there's really nothing you could do about it. Prune juice, because there's a problem with constipation, and then certain medications, you name it, those things are all staining in nature. And of course, any sugar content is going to be, or even things that are false sugars, tend to be problematic.
And we don't do that daily.
No. It's
And Sandra,
once
close
a
your
month,
ears.
maybe, and that's the only thing that I've done. Now, in terms of maintenance around the outside of it, around the wound itself, that's just sterile saline solution and a Q-tip, and occasionally some Neosporin every now and then. But for the most part, your body takes care of that automatically. That's my experience.
Yeah, for me, I'm still able to eat by mouth. I use my feeding tube. I've used it more recently, started using it more recently I take a lot of supplements, and it fills me up. And so we got a pill crusher to use that, but we flush it out once a day. Unless I use it for the supplements, then we'll flush it afterwards to try to get some of the excess that linger in the tube down. And then I also, that's really it as far as like keeping it flushed. My doctor said, hey, just flush it daily. Just you don't want it getting clogged or anything like that. Especially since I'm not having to use it a whole lot, for my nutrition or for all of my meals. And then as far as the wound itself, or not the wound, but around the outside, we just, my wife uses saline solution. After I get out of the shower, she'll wipe around it with saline, dry it off, clean it with saline solution. And even though it's been over or almost a year, I still keep split gauze around the site, just because you still get a little bit of, I don't even know what it is, but it'll kind of build up. It's like this gook stuff, for lack of a medical term. Maybe Sarah could speak to that, but you'll still get a little bit on the outside of that, so it just helps keep it clean. And also, a nurse friend of ours had told us, especially some of the supplements getting caught up. She said you could use Coke, like a soda, like Coke, to flush through to help clean it. Because I don't know, have you ever, maybe you've used Coke to eat away at battery corrosion, in a car? Well, Coke will help. She's like, use Coke every so often, and it can help flush out some of the stuff that gets stuck up in the tube sometimes. So we've done that a time or two when necessary.
Yeah, I would just add to that Justin, what you're kind of talking about around the insertion site of the feeding tube is this like serous drainage that a lot of folks have that just like persists. And it's basically your body is not used to having a hole there. So it sort of like produces a little bit of drainage that can kind of leak around the perimeter. It's sort of like if any of you guys, for those of you who have had your ears pierced, it's similar to that. Like right when you get your ears pierced, you kind of have those crusties around the hole. And then eventually those holes heal up. But with a feeding tube, it sort of persists. And that's fine. That's totally normal. So a lot of folks will keep the split gauze pad on there. Sometimes they can crust and get kind of hard and dry. And so one trick that I'll recommend is a little bit of olive oil to remove the crusties around the site. And then like in saline wash is fine. Soap and water in the shower is a good way to clean it. We don't recommend like alcohol, hydrogen peroxide, anything kind of harsh and caustic because that skin is so sensitive. In terms of the inside of the tube, the best thing you can do to keep it clean is people were talking about is flushing it. So at a minimum once a day, you want to flush it with water. So take a big plunger for those of you guys who haven't seen and really push a big plunger full of water just to keep the inside nice and clean.
Go ahead.
And I saw in the chat, patent means open. So you want to, because it's a tube. So you want to keep the inside nice and clear and open and patent, and you don't want medication or things to clog. So anytime you put medications, which you can crush up with a pill crusher or mix in water and administer through the tube through a syringe, or get your meds in liquid and put it through the tube, which I saw was another question. You want to flush before and after with water to keep it patent, nice and smooth flow.
Okay.
Oh, also really quick, soda water works too. The bubbles I've heard sometimes help break up.
Thank you, Sarah. And related to what you were just talking about, I saw a question come in and it kind of fit right here. Do you still need to flush daily, even if you got the tube early and you're not using it every day?
Yep, that's the recommendation. Even if you don't use it at all, you got super proactively, you're not using it, you still want to flush it once a day with water is the general recommendation to keep it nice and clean on the inside.
Thank you. The next question is for Sandra. It's a series of questions. I'm going to ask all of them, Sandra, and you and Wayne can split up the answers however you want. But how often should the feeding tube be replaced? I know we touched on that already. But how much time does this process take daily? Do many people living with ALS have more than one person doing this for them? If so, is that person typically a professional?
So this will probably vary a little bit from person to person as well, because it depends on how many calories you are trying to consume as the patient. And so that will determine, there's a lot of factors. One factor is how many calories do you need to get in through the feeding tube? And so for Sandra, she's been on tube feeding entirely for almost 2 years, a year and a half. So all of her calories go through the feeding tube. And so you know, her getting the volume of liquid tube feeding in to get the calories in, it means you are probably, if you're going to do periodic feedings as opposed to a drip or a constant infusion, then you're going to do at least 3 and probably 4 feedings a day to make sure you can get enough calories in without her getting an upset stomach or bloated or really uncomfortable from too much liquid in there. So for us, we do 4 feedings a day. She gets, we use Liquid Hope. We'll talk about that in a little bit. And so we do 4 feedings a day, and that gives her adequate calories. Now, the actual feeding takes at least 15 minutes, because if we give it faster than that, she feels bloated and gets nauseated. And I think most people would say that if you give it too fast, that'll happen. So at least 15 minutes, probably 20 minutes will the actual feeding take, and then the actual preparation, because Sandra's on a number of medications. We have to crush those medications, mix them in the tube feeding. She likes her food warm, so we warm it a little bit in the microwave. And so, you know, the actual preparation probably takes 10, 15 minutes. max, 15, 20 minutes for the feeding, and then 5 to 10 minutes to clean up afterwards. So, but we're doing that 4 times a day. And I think that's a reasonable amount of time to figure it's going to take for a feeding. And the question is whether or not these are professionals. So we have basically 4 people in our purview that help take care of her. I have 2 daughters, and they're not professionals. And then we have a good friend who helps as well, and she's not a professional either. They are all, it's not difficult. It's not rocket science. It's very simple to do. And honestly, my 8-year-old granddaughter was actually feeding her for a while and very capable. It's doable with minimal training, but it does take a little bit of time. Did I answer all the questions? Yeah.
I think so. Thank you, Wayne, for sharing that. And I know this question got brought up earlier, but I wanted to go back to it. There's a question that was submitted ahead of the event that just said, is it common for the site of the PEG tube to leak? And if so, for how long would we expect that to leak? And Sarah or Justin, I wondered if you could address that question.
Oh, like I said, I had my tube put in last April, and it still happens. Sometimes, some days, there may be more than other days, but it still occurs for me.
I would say typically, it depends on the person. So sometimes there is, like I said, like a little bit of that serous drainage that comes around the sides. And that might persist indefinitely. And that's just kind of how your body reacts to having like a little foreign accessory placed there. Once in a while, if the tube is swapped out, say more, trying to think of a specific example. Once in a while, the tube size is an issue. So like, say you have a big hole and the tube that's in there is a little bit too small. Sometimes adjusting the tube size can help decrease the leaking a little bit. So if it's excessive or seems to be like a fit issue, sometimes what we'll do is send the person back to interventional radiology or the surgical team to take a look at fit. That's more of a rare thing that we see. I think a lot of people ask about that because they're concerned about infection, which we might be getting at later on. And I'm happy to talk about, but I would just say in general, in my practice, and I would say in general, the risk of G-tube infection is pretty low. It's like low on my concerns for folks. I saw one of the questions in the chat. We typically don't pre-medicate or immediately post-operatively recommend antibiotics in the setting of the procedure in general. And so I would say as long as you're like washing it with the soap and water regularly, the infection rate is super, super low. And that serous drainage that we see is not so much a concern for infection. I'm happy to talk about what that would look like without scaring anybody too much. But I would just say that if a G-tube site were to become infected, like a little localized irritation that blooms into an infection, typically we can treat that really effectively with antibiotics. And it's usually pretty straightforward. Again, if we needed to escalate that to the surgical team, we could, you could talk to your clinical team and they would help you with that.
Hey, can you address Sarah's sanguine fluid there? I don't know that everybody, is keeping up with you regarding that comment.
Oh, like what the drainage looks like? It's sort of
I'm sorry to interrupt, but my husband and I argue or have a discussion regularly because I'm like, oh my God, look at that. He's like, ask your home health goes, like, you're killing me. He's like, no, so.
Let me find, I have another presentation. I can probably try to pull up a picture of it. I might not be able to, but it sort of looks.
It's not blood.
It's not blood. No, it's sort of this like clearish, maybe a little bit of a yellowish tint that kind of like leaks around. It doesn't smell bad. It's clear. It's not cloudy. And it usually dries in sort of like if you've ever had a scab. Have you ever had like a scrape in a scab and then there's like a little bit of drainage around the scab that's like clear, or like, this is gross, if you popped a zit and then you have the little like clear kind of stuff leaking out. It's like that. I'm a nurse, so we like to talk gross over cocktail hours, which is right around the hour we're at right now. So that's sort of the drainage that I'm talking about. If there were an infection, what the best way that I describe an infection is your G-tube site looks angry. It's unhappy to be there. It's super red around the area. The drainage isn't clear and slight anymore. It gets really like foul smelling and thick. We call it purulent drainage, which just sounds icky. It can be smelly and kind of like boogery consistency. And there's like a big difference. So you would know your baseline. And again, I don't usually see infections like that. It's a rare thing. And so it's not something that I would put on the worry list for folks who are like thinking about a feeding tube, but it is a really common question that I get from people. I don't know, Wayne, if you could describe it with your medical background a little better.
Yeah, so I would say that it is you described it well. It's kind of a crusty, if you ever had a child with impetigo, it's kind of a crusty, dried serum, and it's pretty common. We clean Sandra's twice a day. What we use is baby wipes. They're not alcohol. They're for the most part nearly sterile, and they work great. And we just keep them. And so we clean her site twice a day with that. I would say this though: you might see a little bit of blood tinged as you clean it. Now, what that is often due to is what's called granulation tissue, and when that wound channel heals, you often have this granulation tissue which does bleed easily, but it's never going to gush blood. It will be just a little bit of blood tinge on on the wipe. And so we still see that almost 2 years out, and occasionally, not every day, but it's not concerning. If you see a little bit of blood tinged drainage when you wipe around that tube, that's not a problem.
Thank you for helping with that question, Wayne. We are going to, recognizing we just have about 20 minutes or so left for tonight's event. So we're going to jump down to talking about the actual feeding and nutrition part of what goes into the tube. So one question we had ahead of the event is, and I know this was mentioned a little bit earlier, but I want to expand a little bit on it, but can you still eat by mouth if you are using a feeding tube? And Sandra and Julie, I'm just wondering if you can share more about your experiences with eating by mouth while also having a feeding tube.
Sandra's going to play something here. So
I have bulbar ALS and had the tube placed 11 months after diagnosis. I ate by mouth another 8 months after having a feeding tube. I enjoyed every bite of food, and I was glad for that time eating.
Yeah, and I would just add to that. I know it's already been said, there's no problem eating with the feeding tube in place, none whatsoever. You're not going to get, it's not going to make your stomach be upset when you eat. You can eat whatever you ate before you got the feeding tube. And, but it is a huge stress reliever, because at some point you say it's just not worth being afraid to take a bite or to swallow a pill. And then you can switch over to feeding tube completely. But as long as you can eat, that's great. But you can also supplement. Some people decide, you know what, I don't want to struggle eating lasagna tonight, but I'll have dessert. I'll have a piece of cheesecake, and then I'll get the nutrition I need through the tube. So there's a lot of different ways you can do it, but there is no reason in the world you can't continue to eat as long as you can safely, and as long as you are comfortable doing it while you have the feeding tube.
And I do both. I eat food by the mouth, and then I supplement 2 or 3 times a day for the caloric intake. But the other thing I've done is, when you can eat by mouth, do your bucket list of things you love so you can taste them. So this week I bought several stuffed Oreos because I was like, oh crap, I want to be able to taste those again. So just little things like that. But I eat my mouth and I get my yucky medicines through the tube.
Thank you for sharing that, both to Sandra and to Julie. Also, another question for Sandra. Someone asked, are there organic nutrition options for feeding tube users?
Yeah, I'll respond to that. There are many feeding tube options in terms of full nutrition. And that's different than saying just a supplement that's not full nutrition. So it's kind of two different things. So early on, if you're still eating, you may not need complete nutrition. But if you do, there are organic options for that. So I just did a quick lookup today, and so there's basically 4 that are considered complete nutrition. A few of them are organic, and so one is called Nestle's makes something called Complete Organic. And that is a complete nutrition that you can live on that and don't need anything else except water. And there's another one called Kate Farms, which is also a plant-based organic full nutrition that it's going to have all of your vitamins and minerals and everything that you need to survive. Liquid Hope is what we use. It's an outstanding organic plant-based complete nutrition. And then there's another new one on the block called Ensure Harvest that I didn't know about until I looked today. It hasn't been out very long, I'm sure, but it's made by Ensure, by Abbott Labs, and it is also a complete organic tube feeding. So there are options. If you don't need the total package of all your nutrients in it, there's one that you can get from Amazon called Real Food Blends that are just basically meal replacements that are blenderized. They do not claim to be a complete nutrition, but they are usable in tube feedings, and they're fine. Actually, you don't even have to put them in tubes. If you want to eat them like soup, you can. But those are the things that I'm aware of. Maybe there's more out there, but I don't know of others. Now, I didn't mention any of the longevity and plain Ensure and Isosource. And I mean, there's dozens and dozens created by the pharmaceutical companies that are fine if you tolerate them, and there's nothing wrong with them at all. As a matter of fact, Medicare is going to require that you fail probably 3 of those before you can get one of the other organic ones covered. But that's the short answer, I guess.
Thank you, Wayne. A couple questions for Sarah. I'm having nothing by mouth. How do I find out how much I need to take?
That's a great question. So usually what we will do is try to connect our patients with a dietitian or a nutritionist or some sort of a clinical expert in nutrition. And what they'll do is they'll talk to the person about and gather information about their medical history, their weight, what they were eating by mouth. If they're eating even a little bit by mouth or drinking by mouth, they'll log all that in. And then they'll do some calculations and determine what is your total calorie needs in a 24-hour period. And then they'll make a recommendation about what type of formula would we recommend for you, taking into account what's covered by your insurance and what might not be covered by your insurance. And usually what they will do is write up a prescription recommendation. So they might say, we'd recommend X formula at 4 cartons a day to meet 100% of your needs. And they sometimes can even write up a schedule. So your clinical team would be able to connect you with that person. And sometimes it's a dietitian, sometimes it's a nurse, sometimes it's the team. So it varies a little bit depending on the specialist that you have on your care team, but they would help guide you on that.
Thanks, Sarah. How does one go about taking pills through a feeding tube? If the pill is small enough, can I just put the whole pill in, or do I always need to dissolve it or crush it, or what should I do with pills?
So for medications, first thing we want you to do is check with either your clinical care team or your pharmacist, and just confirm which of your medications are okay to crush or be converted into a liquid form. Some medications can't be crushed because of the way they're released. So my general rule of thumb is any med with 2 letters after the name, you want to double check. So if it says ER, IR, XR, extended release, LA, long acting, SR, sustained release, hard stop, and just double check if that can be crushed. So once you confirm that with, like I said, your clinical care team or your pharmacist, then you can get a pill crusher. There's many, many different kinds at CVS or Walgreens or wherever. And then you would just mix the powder medication in a little bit of water. Usually lukewarm water helps it dissolve better. You're never going to dissolve 100% of your med in the water. There's always going to be some like particulate kind of stuff floating around in there, which is why you always want to use the syringe and plunge the meds in, because you need that turbulence to push everything in. Okay, do not put a whole pill in your feeding tube. It'll clog it up, and then you'll be urgently running into clinic to have it switched out, or do a G-tube rescue is what we call them. And then there are some meds that you can get converted to a liquid, and that's really dealer's choice. So like some people feel like it's easier for me to just crush everything up and mix it in water and put it through the tube. And other people really prefer to do liquid, and some people do a combination. Some medications in the liquid form are a little thick and viscous, and people find that they have to mix it in water anyway to get it thin enough to go through the tube. So they're like, if I'm mixing it with water, why not just crush it as a pill? So it really varies, but your clinical team can, and usually it's a nurse, can run through your med list with you and help you figure out how to convert everything so that it's easy to do through the tube.
Sarah, I'm putting you on the spot once again. What can go in a feeding tube? I know I've heard people say, like, I want that caffeine kick in the morning. I want a glass of wine or 2 at night. Can I blend my own food? Can you talk a little bit about what can and can't go in terms of food?
Absolutely. So theoretically, anything that you can put in your mouth can go through a feeding tube as long as it's thin enough, right, to fit in that tube. So you can do your coffee through the tube. The caveats that I will give are temperature, right? So don't put your hot coffee in the tube. Your body will not thank you. It can hurt. So make sure things are like room temp or like a little bit lukewarm. Sometimes things that are ice cold can cause like cramping or discomfort, I hear from folks too. So just keep it like room temp or kind of lukewarm is a good place. Some people do choose to make their own formula, like blend up their own recipes. And again, you just want to make sure that is like the consistency of like juice or water. It has to be really thin to successfully be administered through the tube. The other thing I would just say is if you're getting 100% of your nutrition through the feeding tube, I'm a little bit wary of making your own, just because you need all those vitamins, minerals, nutrients, fats, calories, and it's all packaged in those formulas. They're actually prescription formulas for a reason, and it's just really hard to capture all of that through your own recipes at home. We won't want anyone to have like a deficiency of anything for that reason. In terms of alcohol, which is a really common question, you can put alcohol through a feeding tube. My caveat would be do like a quarter to half of what you would normally drink, because it hits your system a lot faster through the tube. So just be careful of that, and just be mindful. And I think I hit everything. Would anybody else have anything to add on the panel too?
Yeah, the only thing I would add is I would echo what you said about the alcohol. But remember that when you're doing the feeding tube, you, as a rule, push it in or let it run in over a few minutes. If you drink a glass of wine, typically you don't drink that in a few minutes. You drink it over 15 or 20 minutes. So you could do the glass of wine, but you need to do it over the same period of time that you drink it. But I would say if you're going to let it run in quickly, you want to do it a much smaller amount, because the alcohol will hit you very quickly going straight into your stomach.
Thank you for that reminder about alcohol specifically. Sarah, sorry to keep putting you on the spot. The next question is also for you. This question was pre-submitted. Would love to hear commentary about research indicating that a higher BMI. What does the research show about BMI and weight loss?
Oh yeah, this is a really good one. So there's a lot of literature out there about the association between BMI, which is your body mass index, which takes into account your weight and your height, and ALS survival. So what we know is that a lower BMI is associated with a shorter survival, and conversely, a higher BMI is associated with both slower disease progression and longer survival. They've also done epidemiologic studies that show that there's a risk reduction in terms of developing ALS in persons who are overweight and obese, which is really interesting. Additionally, they've done studies on mouse models, so the ALS mouse models, and when they restrict calories in ALS mice, they find that disease progresses faster, and when they high cal supplement ALS mice, the disease progresses slower. So there's a lot of preclinical data and epidemiological data that really shows that patients who are able to maintain weight tend to do better with this disease. So we think that weight is probably neuroprotective. And so what we'll say in clinic, and then Anne-Marie Wills, who's a neurologist out of MGH, did a study back in like 2014, where we looked at like the types of diet. So they looked at high cal versus high fat diet, and they found that for weight maintenance, high cal seemed to be the most successful. So basically what we'll tell folks is that for me personally, I don't mind how you like to get your calories, whether it be paleo diet, keto diet, regular diet, have an ice cream sundae in the morning, just get in as many calories as you can to try to maintain your weight. With that said, it's easier said than done, right? I think Wayne and Sandra were talking about this earlier, the burden of eating. So we say, oh, eat high cal, but you're hypermetabolic, you might have trouble swallowing. It might be physically harder for people to eat. So again, that's where the feeding tube starts to come into the conversation as a way to just directly get in those extra calories, because we know from the literature how weight maintenance can be neuroprotective. So for those reasons, we try to bring that up in the nutrition piece in the beginning when we see patients in clinic, and we talk about what can we do to try to set people up for better outcomes and better quality of life.
Thank you, Sarah. Another pre-submitted question for Sandra and Wayne. My husband had a peg installed in September. While we are not having functional issues, he has been battling nausea and diarrhea. We have tried 3 different formulas and the issue appears to persist. We also have tried spreading feedings out across the day to help the nausea feeling of too much at one time. Any suggestions to address chronic nausea and or diarrhea?
Yes. I would say you really if you haven't looked at trying some of the organic formulas like Liquid Hope or even Kate Farms, but Kate Farms has inulin in it. I think so. For instance, Sandra knew that she was already sensitive to something called fructooligosaccharides, FOS, and she was also sensitive to inulin, and she knew that both of those caused her nausea and diarrhea. So when we started looking at formulas, we found that all of the pharmaceutical grade formulas have one or both of those additives in them. And we ended up looking at Kate Farms. It turns out it has inulin as well. And we ended up with Liquid Hope, which doesn't have any of those. I would say, I would think about the formulas first. I think it sounds like you're already thinking about spreading the tube feeding out over a longer period of time. You could even consider a continuous drip as opposed to bolus feeding as a potential option. What I would recommend is if you're in an ALS clinic and you've got a dietitian, you really need to sit down with them and say, help me understand what else I need to do to try to solve this issue. I suspect, again, just suspect it's probably related to what's going in the tube, not so much the fact that the tube is there. But I do think the dietitian should be able to help you problem solve this. And that's what I'd recommend. I think, now, having said that, our dietitian didn't believe that Sandra was sensitive to FOS and to inulin. It's like, wow, we know that. And in fact, we do know that. But I still think that's the best place to start. That's what I would say.
Thanks so much, Wayne. All right, we just have a few minutes left. I'm wanting to know, do any of the panelists tonight are there things you wish you would have known or you think you should have known but did not know ahead of having your feeding tube placed?
I just thought, for me, this doesn't necessarily have anything to do directly with my feeding tube, but with my procedure, because I rely upon my trilogy nearly 24/7. I can't lay down without my trilogy. And so I made sure to let, on the day of the surgery, let all of the nurses and all of the surgical team know that, hey, I need this machine. I don't need the oxygen, I need air. And so I was able to keep this machine with me the entire time. And when they rolled me into recovery, they initially had oxygen, but I told the nurse, like, hey, I don't need oxygen. Can you help me with my trilogy mask and put that on? And so for those of you who rely on your trilogy a lot, keep that in mind, that you can take it with you and keep it with you. Just be very vocal about that need.
We'd like to echo the same thing,
Yeah.
so that we drag it around with us everywhere we go. I mean, you just tell them this is the way it is.
Yeah, two things. My neurologist that works with two doctors at the UMC that she uses specifically for her peg. So I brought my BiPAP with me. It went into surgery with me, and it stayed in the room with me. So I echo exactly what Justin said.
And this, let me just put a plug in here. I think that's important. And this is coming from a physician, that there's an assumption that when you are under medical care, say in a hospital or an ICU or somewhere, that everyone there really knows how to take care of ALS. And I'm going to tell you that frequently they do not. In other words, ALS is such a heterogeneous disease that it looks different in everyone, whereas somebody with ALS may be able to lay down just fine, and others just literally cannot lay down without a vent, period. Even though they're breathing fine sitting up, they can't lay down. As a rule, they don't need oxygen, but if you end up in the ICU, they're going to put oxygen on you right away. And that's not always the best thing for you. And my point is, advocate for yourself, or someone to advocate for you, to say, listen, this is my wife's disease. Let me tell you what it's like and what she can and can't do. And most professionals are very happy that you do that, because they don't know. And they might assume that they know, but pretty quickly sometimes realize, gee, I don't think I knew as much as I thought I knew. And I just think educating the medical profession is something that's on my mind, and how we do that. But the big thing what I'd advocate for is for nurses and physicians, when they see an ALS patient, tell me about your disease. And if you can't speak someone with you, tell me about your disease, because it's different than the last person I saw with ALS, which was different than the last person before that. Okay. Been on my
I'm gonna jump on that too. When I went in the hospital this summer, I had COVID, and the pulmonologist told the staff that I couldn't go home until I could be off my BiPAP for 24 hours. And I told him he was a blank idiot. And then thank God, my neurologist, who doesn't have privileges at that hospital, came on a Sunday and was so polite. She was like, with all due respect, you're an idiot, but she didn't say it that way. But yeah, they don't know what they're dealing with. So you have to know that you can't lay down, that you can't get oxygen. There's a list somewhere that shows what to know about going into the hospital in the ER. Print it out, learn it.
And your care team also, I'll just jump in to say, like, your care team can also help write up a list of considerations and things specifically about you and your disease that would be important for if I were to go to a local hospital or have a feeding tube done outside of where my care team normally sees me. Like, here's the top 5 things I would want them to know. So use your care team too to help advocate for you, and also ask, like, do you know how to page your neurologist, or the direct line to your clinic? And you can have the teams talk to each other, even if they're not physically with each other, to help weigh in. And we do that a lot. We're on the phones with other hospitals and clinics all the time to share feedback on folks so that we can give them the right kind of support that they deserve.
Thank you, Sarah. I recognize that it's 7:32 Eastern time. Time is over, but with it being 7:30, I have sleep on my mind, and there have been several questions come in tonight about sleep. And I'm just wondering if we can end the night with just the importance of sleep. And I'm wondering if anyone can share a little bit about, do you have suggestions for having trouble? If you're having trouble sleeping with your feeding tube, are there any things we can do? Does a feeding tube ever impact your sleep? Do I need to lie on my side, or can I lie on my back? Or any of those sleep related questions. If any of the panelists have thoughts, we will end with this question.
I sleep on my back and my side. It's really what are you comfortable with? At first, when I first got home after my feeding tube procedure, I mainly slept on my back. But as the site healed and as I got used to it, then I would turn on my side. I still don't sleep on my stomach. I never did that much before. Maybe it's just a middle thing with me, but I'm afraid to lay on my stomach. So I don't do that myself. But sleeping on my back, sleeping on my side works just fine with me.
I would say that the feeding tube, Sandra's typing here, but I would say the feeding tube doesn't really impact her sleeping significantly at all. I do think that eating, this is not just people with feeding tubes, eating just before you lay down is probably not a good idea. And it seems to be more so true in patients with ALS because their stomach's empty a little bit slower, and it's just a bloated feeling. It's just really uncomfortable, but you'll figure that out. But I'll just tell you ahead of time, you want to give yourself a good hour or more after your last feeding before you lay down. You'll be happier if you do that.
Okay, thank you for participating in my sleep question. With that, I'm going to go ahead and close out this call. Like I shared a few times earlier, this event was recorded and we'll get this uploaded to YouTube if you want to rewatch it or share it with anyone you know. And because we had such a big turnout tonight and so many questions being asked, we do plan to have a part 2. We will also work to get a resource guide with all of the resources that were shared tonight out to everybody as well. So with that, thank you all so much for coming and for spending so much time with us. We really appreciate it and we're honored to spend our evening alongside you all.
Thank you very much.
You're welcome. Take care. Goodbye.